Good morning, friends and colleagues. I'm Dr. Bancha from Thammasat University. So today I'm talking about the meniscus radial tear, respect or repair. So this is a meniscus anatomy. You can see the lateral side is more mobile comparing to the medial side. Today we are talking about the radial tear, which is very difficult to treat. It's very similar to root tear, and the tear side is perpendicular to the fiber. So when the radial tear happens, it disrupts the circumferential fiber. So the hoop stress tolerance would be dropped, causing meniscus to be extruded, and the load transmission would go directly to the bone. It's like you have no meniscus or total meniscectomy, same like meniscus root tear. As shown in this biomechanical study in 2012, once the meniscus root tear, the load transmission to the bone is very high. It seems like you have no meniscus. So the meniscus radial tear usually occur in young patients from sport activities or injury. The common location is at the body of the posterior horn of both lateral and medial meniscus. MRI helps us to see the meniscus tear before seeing it intraoperatively. So in sagittal view, you can see the cleft sign. In coronal view, you can see the ghost sign. But the axial view gives us the very good view of the whole meniscus. These are the MRI findings. You can see cleft sign in sagittal, ghost sign in coronal, truncated sign, and meniscus extrusion. So the meniscus root tear can happen in the young and also in elderly patients with different mechanisms. In the young, it's always acute injury associated with ACL, PCL injury, MCL injury. But in elderly patients, it's common in chronic injury with minor trauma or no trauma. It's same like meniscus root tear. So I think the surgical exposure is the key. I propose the technique we call magic point release. You can read this article in Arthroscopy in 2020. So the line draw from posterior cortex to the adductor tubercle, about 1.2 centimeters from the joint line. Use needle number 18. You can open the joint easily. So this is another example of magic point release. You see sudden pop. Okay, draw the line from posterior cortex to adductor tubercle, and then you can address the pathology easier. Sometimes it's not easy to see the meniscus tear if you have very tight joint space. Sometimes the radial tear can be healed. This is an example. This young volleyball player, he twists his knee. He has ACL injury and also there's meniscus tear from the MRI. So when I get in joint to perform the ACL reconstruction with meniscus repair, I found that the lateral meniscus radial tear was healed. Okay, so that's happened in acute injury. This is an example of the patient with ACL injury with medial meniscus radial tear. He has complex tear of the medial meniscus. McMillan test positive. So this patient is a doctor. He said, "Prof, please don't cut my meniscus. Please save it." Okay. So I try to repair his meniscus, even this is a complex tear. Okay. So I make a side-to-side repair and also the longitudinal repair. Okay. And also I add up with some fast fix and then perform the ACL reconstruction. So this is another patient's complex radial tear of the meniscus. He's done ACL reconstruction and meniscus repair 3 years ago. He's doing well and has another injury. He has intact ACL, Lachman is negative, but McMillan is positive on the medial side. So I try to save his meniscus which he's still very young. When I get in, the bucket handle was healed, okay, but there's a new radial tear, okay. So I use the Laplace technique. I pass the suture to the meniscus and make a tunnel to the tibia. So this tibial tunnel make the meniscus more stable, and also you create the bone marrow from the tibial tunnel. Okay, and then I perform the side-to-side repair to the tibial tunnel. This is another scenario. Patient 52 years old. He has sport injury. knee pain. So the patient have lateral meniscus radial tear with ACL and PCL injury. Okay. So when I get in the joint, I found that he has torn his meniscus, and the meniscus dispressed to the back. I need to do a lot of release from the back and try to save his meniscus by repair it side to side. Okay. And then I'm performing the ACL and PCL reconstruction. So the radial tear together with the ACL or PCL reconstruction, the chance of healing is better because you get some mallows from the tunnel. Okay. And then I pass the ACL and PCL graft. So this is the intra findings. We did the ACL, PCL reconstruction and radial tear repair. The patient doing very well after the surgery. This is another scenario. This patient was done the lateral meniscus repair, but it's failed. So I need to come back again to do the revision surgery for the lateral side. So 2 months after surgery, the patient doing well, McMurray test negative, and good healing of the MRI. So this patient have the sequelae of chronic radial tear of the meniscus on the medial side. So he has severe osteoarthritis. So I need to do the STO for him. Cannot repair his meniscus. So he's my good friend. He's orthopedic surgeon. He's a past president of ISKAST and also TOSUM. He torn his meniscus both sides. You see he has radial tear of the posterior horn of the medial meniscus. So when I get in, I found that he has the torn radial meniscus. So first we need to do trephinations. Okay, and also has extrusion of the meniscus. I need to do the extrusion reduction for him too. Okay, this is extrusion reduction to reduce the tension of our repair site. Okay, so that is after the extrusion reduction, and then I do the side-to-side repair of the meniscus. For radial tear, I try not to shave the tissue to avoid the gap. You should do over reduction because over time this gap will be widened. Yeah. So when you do repair using the fast fix, always repair upper and under surface. So he got very good outcome and go back to sports. Okay, he's my good friend. I did that for him both sides. So in summary, we all know that radial tear of the meniscus is not simple. It's complicated and difficult to heal, and it's difficult to repair also. So we should try to repair the meniscus as soon as possible. Early diagnosis, okay, to save the meniscus. And you can save the biomechanics of the knee joint. But in some situation, you must surrender its nature. Just make it stable. Thank you so much. Thank you so much, ISKAST, for the invitation. Hope to see you again in Thailand. Bye bye and have a nice day.